everyone. Welcome to Being Patient Brain Talks. I'm Deborah Kahn, founder of Being Patient. Today, we're going to talk about behavioral symptoms of dementia. In particular, what parts of the brains are being impacted and what types of behavior can actually be a symptom of Alzheimer's or other dementias. Joining us is Brent Forrester. He is the head of the psychiatric department at the Tufts University School of Medicine. We met in Madrid at a conference, and I thought he had great things to say, adding a lot to my knowledge. So we've invited him to join us here today. Brent, great to see you, and thanks so much for joining us.
My pleasure to be here, Deborah.
Okay, so I was actually reflecting on this on my run this morning that, behavioral symptoms are really one of the most challenging parts of dementia, whether you're a person with a diagnosis or you're someone who has a loved one with dementia. And perhaps they're the most understudied part of this disease. So I'm really happy we have you here today to kind of delve into this. Let's start first with early signs, because I think that's what we hear a lot of. My loved one wasn't the same person. There's often characteristics like paranoia that come early that aren't part of the person you once knew, but they can be an early sign. So let's just start there with, what are some of the behavioral early signs of dementia?
Deborah, again, thanks for inviting me to be part of this today. So I'm a geriatric psychiatrist by training, and my perspective is that what you said is so critically true. It's the anxiety, the agitation, the depression, the paranoia, the aggression sometimes that are not only universal over the course of the illness of dementia, but they truly are the factors that drive the burden of this illness for both individuals with dementia and especially their loved ones who care for them. And if you look at why people with dementia wind up in long-term care or in the hospital or in the emergency room, it's not because of inability to remember someone's name. It's because of these behavioral symptoms. This is often the final straw that breaks the camel's back, if you will. And so they're critical to recognize. And the good news, the really good news is they're highly treatable, but they need to be assessed, and we need to figure out the cause. So we can get to the cause later, but you mentioned like what's common and when. So in the early stages of a memory disorder like Alzheimer's disease, which is one form of dementia, it's very common that there's people are aging and they're becoming more forgetful, and they feel depressed, or they feel lack of motivation. Sometimes we call that apathy. Or they feel worried and anxious, and they just can't put their finger on it. And it's often the case that, memory loss is certainly an early sign of Alzheimer's, but frankly, these mood and anxiety symptoms are clearly an early sign, potentially, of dementia. It may be that it's the underlying disease process coming out, and it's manifesting with these psychiatric symptoms. But what's really important to figure out when I'm assessing somebody who's coming to me with, say, depression or anxiety, and they're in their 70s or 80s, is this the first time in your life this has happened? Or do you have some lifelong recurrent history of depression since your 20s and 30s, and now you happen to be in your 70s and it's another episode? That's a big difference, because if someone has never had these symptoms earlier in life and now they're having them, that's when it's more likely to be a medical or a neurological cause. It's not always dementia as the cause, but that's definitely one of the causes. And so sorting it out is sometimes tricky. And families try to figure it out, but that's not your job as a family member. You need to bring your loved one to a professional who can assess what's a medical problem, what's a psychiatric issue, what's dementia with a psychiatric issue. And once you figure out the cause, then you can come up with the right treatment.
Okay, I want to talk a little bit in specifics, because I think that's what a lot of people will relate to. Dementia obviously being the broader umbrella term for different types of neurodegenerative conditions. Alzheimer's, FTD, Lewy body, CTE. We have a whole host sitting under that umbrella. My mom has been diagnosed with Alzheimer's. I have a friend whose mom was diagnosed with frontal temporal lobe dementia. But what was interesting to me is a lot of their symptoms, obviously she was misdiagnosed, as many people, my friend's mom, and told it was Alzheimer's, only to be later told it was frontal temporal, which we see all the time. But what was interesting to me is one of the initial symptoms in both of them was this paranoia that didn't exist. Like, who stole my thing? Who took my, someone came in the house and stole things. It was exactly the same. They mirrored one another. So not surprising that a doctor would conclude, okay, that's we hear that from people who have been diagnosed with Alzheimer's all the time. It's that paranoia that appears quite early and is not the person who we once knew, right? My mom never thought people were coming into the house and stealing her jewelry or even a pen, right? But it all of a sudden became an issue. What do we know about those early signs in terms of how is it impacting the brain to mirror these symptoms that kind of cross dementias in some cases?
When it comes to understanding the changes in the brain causing symptoms like paranoia, that's an area which honestly is incredibly understudied. In fact, there's a fair amount of research going on right now, and the NIA, the National Institute of Aging, is trying to support research to uncover the biology of these symptoms like delusions, paranoia, anxiety, depression, and so forth. So paranoia often doesn't happen in the very, very early stages. But what might happen is that the person had the disease in the brain for 5, 7 years and no one knew it. And so it looks to the family like it's the early stages, but honestly, the horse has been out of the barn for a while. When someone's developing the kind of delusions you just described, Deborah, where somebody either inappropriate, like mistakes a loved one for someone else, like doesn't recognize them and so thinks it's someone else, or can't find an object around the house and comes up with a story in their mind that someone stole from them, we call that a delusion. A delusion is a fixed false belief by definition. It says nothing about why, right? It says nothing about the cause of that delusion. What often happens in Alzheimer's disease, because the classic cognitive symptom of Alzheimer's is the inability to store new information, that person cannot remember from moment to moment what just happened. And if they can't find something, it's the brain's natural tendency to come up with a story about why. Now, I can't explain to you why it goes down the paranoid route of an explanation as opposed to, oh, I must have just misplaced it. But that paranoia is definitely rooted in specific brain regions. And the hippocampus is the part of the brain where we store new information. The parietal lobe is sometimes the part of the brain that allows us to, it's like spatial awareness and things like that, and insight. And the lack of insight that we often see in people with dementia, the awareness that they have a problem is often a parietal lobe impairment. That sometimes feeds into the paranoid beliefs that people have in terms of why does that even happen. And parietal reduction in function early on is we see that biologically with Alzheimer's disease. So it's not surprising.
Is parietal in your frontal cortex? Where is the parietal?
Frontal cortex is here behind your forehead, and the parietal lobe is right next to it, like over your earlobe. And then the
What is the parietal lobe responsible for usually?
Well, it's responsible for some of those things that are hard to measure, like awareness and insight, and appreciation of illness. People who have had strokes in their parietal lobe will often develop a syndrome of neglect, where they're unable to recognize that they have, or they think that they have, that this is part of their body. But the thing that we often see in parietal deficits as well is a lack of insight into an illness or into a deficit. So a deficit could be a neurological hand function thing, or it could be a memory thing. But in any case, the most important issue about these symptoms are that we figure out why. Because it could be, if it's an acute onset of a paranoid delusion in someone who never had the problem, it's not schizophrenia all of a sudden in a 70-year-old, right? That's not the problem. And it may or may not be Alzheimer's or frontotemporal dementia or anything else. It could be an infection, especially if it's an acute onset. So we really need to make sure that families are bringing their loved ones to medical attention to find out the cause. I cannot stress that highly enough, because if we don't get the cause right, and you bring your mom, say, to a psychiatrist who doesn't think about what the cause is, and I give your mom a drug to treat a symptom that's caused by something else, it's not helpful, and it potentially could be harmful.
So this is where I'm very curious. So let's just create a scenario here. Maybe a 70-year-old comes to you and says, "I'm really depressed. I don't know what's wrong." And you're going to ask them if they have a history of depression. And if the person says, "No, I have no history," what's the next thing you're going to look for? And how do you know when depression is associated with dementia?
So a colleague of mine literally asked me this question last night about a patient of hers that she's been treating for depression. Now, this person of hers, same age, 70, had depression on an antidepressant, and now has a brother with dementia, and the patient with depression is worried that they now also have dementia. And she says to me, this is a highly trained, skilled, decades-long, clinician who's not a geriatric psychiatrist. She says to me, "I don't think it's dementia." And I said, "Well, how do you know that? What workup have you done?" So what I would try to find out is, first of all, the history. Sometimes it's helpful. I would say always it's helpful to hear from families what they're noticing. Because even, like I said, the lack of awareness. So even though the person may say, "I've never had it before," well, what does the adult daughter think? Or what does the spouse think? Or even the grandson or daughter. So getting collateral, I call that, information from family is number one, like their perspective. Second thing is, let's get an objective measure of depression. I can ask you the questions that meet the criteria, but I could also give you a rating scale to get a severity score. And then very importantly, no matter what, I'm going to do a cognitive assessment. And I'm going to see on a basic test like a Montreal cognitive exam, test 8 domains of cognition in about 15 minutes, and see, are there any deficits? If the depression severity is high enough, it will affect cognitive performance. If the depression severity is normal, there is no depression now, then what you're seeing from a cognitive assessment is probably truly reflects cognitive performance. So anyway, that's the beginning, is the history from the person and their loved one, and it's a further assessment of mood and cognition, and then we go from there.
Can we see depression on the brain? Is there a particular area? Is there a way? I think we talked about this. What do we know that's happening inside the brain when somebody is diagnosed with depression?
It really also depends on the age of onset of it. So if you see somebody in their 30s with depression, is different than an 80-year-old with depression in terms of biological cause and so forth. So let's talk about your 70-year-old patient that you just mentioned.
Where it intersects with dementia.
Right, who had no history. In those situations, first of all, if anyone were to tell you that we really understand the cause of depression, they would be lying to you. We don't really know. We know associated findings in the brain that are correlated with the symptoms of depression. Remember, depression is a syndrome of symptoms. It's not a disease that we can identify, like Alzheimer's is defined by plaques and tangles in the brain that we can see and measure. Depression, not so much. With depression, we know there are neurochemical changes in the brain, and we know that in part because people respond to certain medications that alter those chemicals in the brain. We also know that depression is an illness that involves brain circuits. And so in somebody who's, say, in their 70s, who's now getting depression for the first time in their life, in my mind, and just is one example of what you're getting to, Deborah, I want to know if they have risk factors for small strokes, like high blood pressure or diabetes or high cholesterol. And in many cases, you'll see somebody who presents with depression for the first time in their 70s, and it turns out they got high blood pressure. And then it turns out that you get an MRI of their brain, and they have these small little white spots scattered throughout their brain. And there's a theory called vascular depression, which is a hypothesis of late onset depression that's associated with not memory loss, but executive dysfunction, like an inability to plan or to organize or to make decisions. And in that case, you're disrupting with those mini strokes the connections between the frontal lobe and the lower brain structures called the subcortical brain. And in that situation, people have depression, and it's very frustrating for the person. It's also very frustrating for the family members because they've never seen this in their loved one before. And that depression is not a sadness and melancholia and hopeless depression. It's an apathetic depression. It's a, I don't feel like doing anything depression. It's a, can't initiate or initiate activity depression. And that is a very difficult to treat depression, but it really speaks to this vascular brain change that often occurs.
So would that be in the case of a vascular dementia rather than an Alzheimer's, or is it across the board?
If you follow someone like I just described with vascular brain changes and the apathetic amotivated depression and executive dysfunction, if you follow those people for 5 years, 50% will have dementia. And again, it may be a vascular dementia at that point, but commonly, and this is an important point for you all to understand, if someone presents with memory loss and cognitive changes and is diagnosed with dementia in their 60s, it's usually a singular brain disease. But the older you get, especially into your 80s, it's way more common to be multiple brain diseases. And the most common co-occurring brain diseases are Alzheimer's type dementia and vascular dementia. And we could debate forever, like, how do you really define vascular dementia? Is it like one big stroke, or is it these mini strokes, or some combo? But that combination is so much more common in later life.
Yeah, it's so interesting. I want to get to a question. Chris Boyce is asking right now, and he said he has a question about out-of-body feelings and dementia, like you feel like you're floating outside your body. I'm always told it's anxiety, but I live with this 24/7. From the second I wake, don't get me started on paranoia. I can't even walk out my front door with me thinking people are watching me or following me. Now, Chris is one of our really loyal members and attends a lot of these talks, and he had TBI, CTE, we're talking about in his case, which he shared with us.
Well, Chris, thank you for that question. It's so hard for me to comment on anyone's experience with such little information, but when I hear somebody talk about an out-of-body experience, my mind goes to symptoms that we see often a lot in people with psychiatric illness called dissociation. And it's a phenomena where we don't feel connected to our bodies. We feel like we're outside of ourselves, or we're looking at ourselves from up above or from outside of ourselves. It's a real disconnection. And we see dissociation phenomenon in people who've had some traumatic injuries or have been exposed to trauma. And so it could be related to that. And no matter what, it's likely related to the part of the brain that's been traumatized, in your case, by whatever the injury was or wherever it occurred. You could consider it to be an anxiety-like phenomenon, and I'm curious what treatments you've had to try to treat it. But it really, I often think of it as dissociation, and it's often associated with the exposure to trauma.
Interesting. Well, that would make sense in his case. We have a question from Charlie who's asking, what about early onset Alzheimer's? Is it the same with respect to depression? I'm 52. So we talked about 70s. What about people in their 50s?
That's a really good question. I would be guessing if we actually really knew that there was a difference in the symptoms of early onset Alzheimer's disease, if early is defined by 52 versus 70. In other words, I don't think the age matters as much as what's going on in your brain. If it's happening to you at 52 or if it's happening to you at 70, the process of Alzheimer's disease is usually pretty predictable in terms of where in the brain it starts. But what's not always predictable is that, and I say this often, if you've seen one person with Alzheimer's, you've seen one person with Alzheimer's, because everyone has a little bit of a different pathway. But I would think of it the same way, that the number one thing we do is figure out why, if you've never had it until now, 52, anxiety, depression, what's going on biologically in your brain? Are there other medical factors? By the way, I didn't mention this before, but it's really important, Deborah. I'm a psychiatrist, but I spend most of my time figuring out the medical causes of psychiatric symptoms, because if I miss them, I'm missing a treatable opportunity. And I worry that people go too long with symptoms that they don't figure out why. Just ask the question why. If your 12-year-old developed depression, you would want to know why. So when your 70-year-old mom or your spouse develops depression, you want to know why.
100%. What about, I'm listening to you talk about the different symptoms and everything, and I'm just wondering, how much do we know the relationship between glucose metabolism and, behavioral symptoms? Because I think, we talked a little bit about vascular, but glucose metabolism has a lot to do with cognition as well. And so do we know any of that? And also, Can we treat any of these symptoms with those imbalances in chemicals like dopamine, serotonin, like whatever we're talking about here? Can we treat it to try, like, just despite whatever the cause is, whether it's CTE, whether it's Alzheimer's disease, is there a way to kind of restore some of those chemical balances so that it actually helps the symptoms of the person? How do you treat it?
So the first part of the question was around specifically glucose metabolism, but let's just say, are there any characteristic findings on brain imaging, whether it's metabolism changes, structural networks that you would see with what's called functional MRI, or MRI findings in like a structural picture of the brain? Are there any characteristic findings that would be associated with certain psychiatric symptoms, depression, paranoia, et cetera? This is not a clinical, these are not clinical tools, okay? I don't go around getting glucose metabolism studies on people with depression who are older if we know they don't have dementia, because I'm still going to treat their symptoms. Because I really don't understand as a clinician, no one does, the relationship between these glucose metabolism symptoms and depression, okay? And I say this because the world of psychiatry, unfortunately, is a world where we don't have biomarkers that predict underlying cause or response to treatment. That's some of the research I've been involved in with certain kind of imaging studies. And a lot of my colleagues have with PET scans and with MRI scans and things like that. So those are great questions. There's a lot of research in this, and there's a lot of effort to try to understand the biological causes of these psychiatric symptoms. In dementia, your second part, if we use psychiatric medications to treat paranoia or depression or anxiety, does it work in dementia? The answer is yes. However, let's take depression, okay? The biological cause of depression in a 75-year-old who's never had depression is very different than the biological cause of depression in a 30-year-old who has never had depression, right? Not only is your brain 45 years older, but if you have dementia now, you have plaques and tangles in your brain, you may have mini strokes in your brain, you've had inflammation in your brain, you've had degeneration of brain tissue. Why would we expect the medicines to work the same? So there's a lot of research that's going on now and needs to continue to find out, do we treat someone who's 75 with dementia and depression differently than a 35-year-old? The answer is yes. And it depends on the symptoms in some ways. Like, here's the way, I don't know how much you want to get into this, Deborah, but some of our medications like Prozac, Zoloft, Paxil, the SSRI medications, they work really well for depression in late life. But when you have depression plus dementia, they don't work as well in that same aged person who's older when there's dementia because of these other biological factors. So if the person's on Zoloft at a good dose and a little bit better, but not fully better, then I look to see, well, what are still the symptoms that remain? Is it anxiety and worry? Is it sleep? Is it feeling blah or lacking in motivation? And based on that, I will choose a medication to go along with the SSRI to try to improve symptoms. The most important point here is if you feel this way or have a loved one that feels this way, there are treatments that can be used to help you feel better and function better. And if anything about dementia is treatable, it's these behavioral and psychological symptoms.
So what's interesting, well, what's actually astonishing is we just had the first FDA-approved drug to treat symptoms, behavioral symptoms of dementia just in the past year or so, right? And so oftentimes people are tweaking with other antipsychotics, and we've heard so many stories like, oh, I had to, it took months before we got the right one, or my loved one got so much worse, or they were on the wrong type of medication. I kind of feel like what's terrible is people are kind of left there saying, okay, well, there's nothing else, try this one. So I guess my question is, where is it all heading next? Where are we getting better? And I know you've also spoken a little bit on cannabinoids, and we get that question all the time. Are they a good way to treat behavioral symptoms of dementia? So two parts here.
Yeah.
What's coming up, or is there anything coming up? What are some other alternatives that people should be looking into, including cannabinoids?
My personal opinion is that drug development for behavioral symptoms of dementia is so far behind where it needs to be And there are a lot of reasons for it, in part because the world of dementia care has been dominated by the amyloid hypothesis. And I guess the good news is if these drugs work, like the anti-amyloid therapies, one would presume they might also secondarily help some of these symptoms as well. And the data on that is forthcoming. But in terms of your question about the first ever approved FDA drug to treat agitation and dementia was about 1.5 years ago. It's an antipsychotic medication called brexpiprazole. There are many other atypical antipsychotics, we call them, that have been studied for decades and show that they work and that they're relatively safe. There are side effects, there are worrisome side effects, but they've not gotten FDA approval for a whole variety of reasons. There is some drug development in this area, but it's not consistent, and it's basically been the repurposing of existing medication.
Well, we're just getting a question about Rexulti, which is one of those repurposed psychiatric drugs that is now being tested for treating Alzheimer's disease symptoms. Would you prescribe that to a patient right now?
So that's the drug we just mentioned. So Rexulti is the brand name for brexpiprazole. That is indeed the only FDA-approved treatment for agitation and Alzheimer's. There may be others in the next year, so there is drug development. But that medication shows that it reduces agitation in people with dementia of the Alzheimer's type. And there's a dosing, dose response kind of thing we can follow. But what we don't have is head-to-head studies. Like, I don't know if that's better or worse than drug B, olanzapine or risperidone or Seroquel. However, for patients who have delusions and they're agitated and they're at risk of harming themselves or others, and they're distraught and their families are distraught, 100% I would prescribe that medication. And then I would warn the families that there are side effects. It could cause sedation or unsteadiness on their feet or dizziness when they stand up, or it could cause an elevation in blood sugar or diabetes, or it may increase the risk of stroke or even mortality, which is very, very low. But those are the things that have to happen. We have to have these risk-benefit discussions. And I've never spoken to a family member, like you mentioned your mom, if her delusions are to the point where they're scaring her, keeping her up at night, making her feel anxious and worried and distraught. If the agitation is being driven by the paranoia, I would recommend an antipsychotic, and no family would ever say to me, don't give my mom an antipsychotic for that because it might cause mortality when she's so distressed to begin with, because the risk of the mortality is so low.
Is great.
Let me just say on cannabinoids really quickly. The world.
Wait, hold on. Before we go to cannabinoids, Kathy's asking if drugs like Rexulti work on other dementias like Lewy body.
Really great question. Lewy body dementia is one where we have to be careful with any antipsychotics because it's a Parkinsonian-like dementia, as you probably know. Any of these antipsychotics could make those Parkinsonian symptoms worse, not just the tremor, but the balance and the risk of falling, and maybe even confusions. Not that we wouldn't use it, but we try other things first. Okay. Cannabinoids are so understudied for all the things that people go to dispensaries and everything for. Do we really know? No. So the study that I did, that you and I spoke about, Deborah, is a study of a synthetic THC compound called dronabinol or Marinol. Dronabinol has been on the market since 1985 for 2 other non-dementia indications. And so it's available and any doctor could prescribe it. But we studied it in people with Alzheimer's disease with agitation compared to placebo over 3 weeks and found that 5 milligrams twice a day was both effective and safe. And our paper is currently just about to be submitted for publication. So, but it's one study, and there'll be some caveats about the patient population we had and their age and their other medical factors, et cetera. But this is a known compound. We know how it works. We know its biology. And I think it's a promising avenue, but not
How does it work? Like, why are you not surprised that you're seeing good efficacy?
There are a couple of cannabinoid receptors in the brain, one of which mediates its calming effect, and one of which mediates its other biological effects like reducing inflammation, possibly even reducing amyloid accumulation. But it's really through one of the cannabinoid receptors that it mediates its calming effect. It has unfortunately, it also has euphoria effects, and it has effects on potentially creating psychosis at the wrong dose in the wrong person at the wrong time. But this one, we kind of know the dose. We've been studying it. We know the side effects, minimal drug interactions. But when you go to a dispensary, you don't know what you're getting. You don't know what's
No.
in there. You don't know the dose. Certainly don't know the other compounds beyond the cannabinoid.
So how long would it take for something like that to be used to treat dementia? I mean, obviously there is, you can get, there's marijuana is legalized in different forms and at different
Well, it's
dispensaries,
hard.
but
Yeah, it's a really good question. I get to ask this all the time. I think I don't know what to tell my patients and their families when they say to me, what should I ask for at the dispensary? Because I don't know what to tell them. I really don't, because they
you
may
don't
tell
know
you
how it's
what's in there, but
cultivated or
you
what
don't
they're, yeah,
know. And when it's
yeah,
a plant-based product, and I'm talking about a synthetic product, when it's a plant-based product, there are all sorts of other compounds in there too that may have other psychoactive effects that are unpredictable. So um, but synthetic THC in the formulation we studied, and we're not the only people to study a formulation of synthetic THC. There's an abalone trial from Canada that was also positive. I think we're at the point where these FDA-approved cannabinoid therapies that are synthetic, again, manufactured THC, they have efficacy in agitation. So if I had a patient, I mean, I've been doing this now for 20 years, so I would certainly do this. If I had a patient with agitation in the setting of Alzheimer's, that was not related to psychosis, and there was no other major medical cause of this, like an infection, and an antidepressant, say like sertraline or citalopram, didn't work, I would definitely try this. It's really well tolerated. The problem is availability and access, because it's generically available, but there's a manufacturing issue.
yeah. Okay, so just to end with, just to help our patient population, or family members for that reason, when you're going to a doctor at that very early stage and you're describing behavioral symptoms, like what should be included and what should be some of the questions that you ask your doctor in order to kind of get a better diagnosis early on? And I'm talking like very early stage, right? Like going to the doctor for the first time because you realize it's just not normal aging, it's something more serious. What should that conversation look like from your perspective?
Um, Partly, I would say you're going to go in equipped with more knowledge than some of the primary care doctors you see after a conversation like we just had. So depending on the doctor you see, you may need to go find a specialist if this doctor is not pointing you in the right direction. But the kinds of things you may want to highlight are that these symptoms are new to you, and how long have they occurred? And ask the question about the cause. Like, is this an anxiety or depression problem like I might have in my 30s? Or might there be something else going on? Because I keep forgetting where I put things and I can't remember what I just did yesterday. A lot of times, especially primary care clinicians will essentially say, well, you're 75 and you're a little forgetful and you're anxious, so it must be the anxiety causing that problem. As we start now to utilize in clinical practice biomarkers, like blood-based biomarkers that tell us the brain pathology of Alzheimer's, like plaques and tangles in the brain, that we're going to learn now from just getting a blood test, that's both a blessing and a curse. It's a blessing because we're going to have some sense if there's any connection between the brain biology and the symptoms that you're describing, depression, anxiety. In other words, the first sign of Alzheimer's could be anxiety or depression. And now we'll have a quicker way of knowing it biologically. But the curse is, if we get lazy, and I'm talking about clinicians, and we overinterpret or underinterpret blood tests without a full assessment of the patient and their family to understand what's been going on in the history, we're likely to make the wrong diagnosis and provide the wrong treatment. So even though they may want to start getting a blood test to look for what's going on in your brain, fine, but make sure the interpretation of that test is done in the context in which you are experiencing these symptoms.
Okay, and just really quickly, because this occurred to me when we were talking and I forgot to ask you, does this mean that psychotherapy without medication for people with dementia is not recommended because it's maybe caused by the disease and, a therapy session probably won't help depression? Is that fair to say?
Actually, it's a wonderful question, and colleagues of mine at Cornell have developed a specific psychotherapy intervention for people with depression and early stage dementia and MCI, mild cognitive impairment. So I would actually say Yes, psychodynamic psychotherapy and reliving of the past and traumas earlier in life to inform now. It's always interesting and educational, et cetera. But specific, targeted, evidence-based psychotherapies to improve anxiety, depression, and people with cognitive impairment, they're out there. They're out there. They're very newly being studied, but they work. They work very well. They work well with medication. They work well alone. Those are the kinds of interventions that work, and they're generally of a cognitive behavioral nature. Any psychotherapy that requires someone to learn new information can be challenging if you have that inability to learn new information. These psychotherapies are much more targeted to try to improve activity, behavior, engagement with the world around you, and so forth, and they work.
Brent Forrester, thank you so much. I find this so necessary and interesting, and it's so hard for people to get really good information on behavioral symptoms. And I'm glad, I mean, I feel like a lot more research needs to go into this. So thank goodness people like you are researching it. It's a big, it's a big pain point when you're living with any kind of cognitive decline. So thank you so much for sharing, and with your time and expertise. It's much appreciated.
My pleasure, Deborah, and thanks to you all for listening. And it's wonderful to really have the opportunity to share these things, and I'd love to come back at some point.
Oh, absolutely. We will have you back. It's such a great need.
Right.
So if anyone missed any of this conversation, don't forget to go to our website, beingpatient.com. Sign up for our newsletter. That's when we tell you about interviews like Brent's. So thanks to all of you for watching, and we'll see you next time. Thank you.
Thanks, everyone.